Hello. In this episode, we will discuss the orthopedic appliances, where they depend on external forces to make a skeletal change. It is usually in the range between 300 to 500 grams, and it is applied in an intermittent duration. It is opposed to the orthodontic force, where we apply mild forces between 50 to 100 grams for a prolonged amount of time to cause a movement on the tooth level. These orthopedic appliances apply heavy forces and gain the anchorage from external bones like the occipital, the parietal, frontal, cranial bones, and the cervical vertebrae. The most widely used is the face mask, the headgear, and the chin cup that we will discuss today. This type of appliances are usually worn from 12 to 14 hours per day, mostly in the night time, because after the school hours and during the night, because there is an increase in the growth hormone in this time. So it is advisable to be worn in the mixed dentition period, where the active growth occurring in this phase of growth. So the main concept of these appliances is to apply a heavy load for a short amount of time to make a skeletal movement and to produce an helenization on the periodontal ligament in front of the tooth, which will prevent any movement in the tooth. Let's start with the headgear. It is used to manage the skeletal class 2 malocclusion by applying a growth modification on the maxillary arch. It can be used to do some distalization of the maxillary molars, and now we will see how we can do both of them, how we can get an tooth movement and a skeletal movement. What is the mechanism? This is the headgear, where we have this part that goes inside the mouth, and this is the band that is attached to the external bones. We have discussed previously the concept of center of resistance, which means that when we apply force to this center, we will get a bodily movement. And we have said that the tooth has a center of resistance. The maxilla has a center of resistance also, which means that if we direct the force to it, we get a bodily movement of the maxilla hole without getting any move of the teeth underneath. So it is located between the roots of the premolar teeth, and it affects on the maxillary sutures to enhance the growth in the direction that we want. It restricts these types of appliances restrict the growth of the maxillary arch to treat the class 2 malocclusion that is applied during the period of active mandibular growth. If we apply the force through the center of resistance of the molars, which we know that the center of resistance of the molars is in the in the root region. So we will get a bodily movement of the molar. If you want the distalization of the maxillary molars, this is the vector of force application, and if we applied this force below the center of resistance of the molars, we get distal crown tipping. And if we applied it above the center of resistance molars, we will get distal root tipping. So the direction affects the type of movement we get. Also, the headgear can have a cervical attachment, and it acts below the center of resistance of the maxillary molars. So the force vector will result in distalization as well as extrusion of the molars. The extrusion of the molars is not desirable in class 2 management malocclusion, so we can use the headgear that depends on the occipital force and acts vertically and posteriorly through the center of resistance of the maxillary molars, resulting in intrusion and retraction of the molar, which is favorable in class 2 management. This is the cervical headgear and this is the occipital headgear. In some cases, we can do a combination of the cervical and the occipital headgear. The reason for that is to distribute the external force over more surfaces, and it provides convenient modification on the direction of the force vector. So the magnitude can be distributed equally between or unequally between the two attachments to alter the direction of the force vector. However, this, although gives us more space of force modification and provides patient comfort, but it requires more cooperation from the patient because there is an increased number of parts that they have to wear. We can alter the force vector by varying the length of the outer bow and changing its vertical height. We apply 400 to 600 grams per side for 12 to 16 hours throughout the night during the mixed dentition period, and it is maintained until the cessation of the maxillary growth. For females, it is in the range of 8 to 10 years, and for males between 9 to 11 years. If we applied excessive force more than 1000 grams, this will result in a trauma to the periodontium, and forces less than the appropriate magnitude will produce dental changes rather than skeletal changes. This is a case that was treated using the headgear. We have seen that this is the intraocular acrylic that is attached to the bow externally, and the force is applied to retrude the maxillary arch. We have seen the improvement in the face profile. It is contradicted in open bite patient and long-faced with lower facial height. Another type of headgear is the high pull headgear. It derives anchorage from the parietal region, produces intrusion and distalization of the maxillary molars. It is used when vertical maxillary excess is also to be addressed. So it produces modifications in the vertical direction. Now let's discuss the face mask, or it is called the reverse pull headgear. This is it. Uh, it produce forward movement of the maxilla by exerting mesial force on maxilla with an equal and opposite force on the chin and forehead. It is used to treat class 3 malocclusion to the maxillary deficiency. The mode of action of the face mask is that we know that the nasomaxillary complex is influenced by the changes occurring of the surrounding sutures, like the frontomaxillary, the nasomaxillary, the zygomatic, temporal, and others. It produces forward displacement of the maxillary complex by affecting significant changes in the sutures. So it affects the sutures around the maxilla that will produce an growth in the maxilla and can be used to treat the class 3 malocclusion where there is a deficiency in the growth of the maxilla. The force is in the range of 300 to 500 in primary and mixed dentition period for 3 to 16 months, and the optimal time is in when the upper central incisors has erupted, which demands a long period of wear. So it demands highly cooperation from the patient. This is the face mask parts. This is the chin part, and this is the forehead cap. It has several types and shapes. Now let's discuss the chin cup. The chin cup covers the chin and it is connected to a headgear. It is aimed to restrict the forward growth of the mandible. So the headgear restricts the growth of the maxilla. The face mask increases the growth of the maxilla, and the chin cup, it restricts the growth of the mandible. The occipital pull chin cup is one of the most commonly used chin cup. This is the occipital chin cup, and this is the vertical pull chin cup. It can be also used to treat proclined mandibular incisors. At the first 2 months, we apply mild force, 150 to 300 grams. Then we increase it to 450 and 700 grams. And the patient wear it for 12 to 16 hours.